County Welfare Directors Association. And CWDA represents the 58 county human services, social services directors. And we work very closely with child welfare directors across the state to support them in their work in serving kids and families. And so pleased and happy to be here today. And then I'll kick it over to Andrea.
Hi, Andrea couldn't make it today, so my name is Laura Krizwicki. I'm with Child and Family Policy Institute. Thank you all for being here. We are collaborating with CWDA to help host these meet and greets with counties and our managed care partners. So thank you all for being here today. Just to let you know, also, we are recording the session. We will drop in the chat a link to our CFPIC website, which will host not only these sessions with the managed care plans, but we will also throughout the meeting today take and write down all of the questions that you all have, and we will also be hosting that on our website also so that you can go back and see that too. So thank you all for being here, and we'll go ahead and kick it off to our Kaiser folks.
Hello all, welcome this morning. I'm going to start sharing my screen and then we can start with the presentation here with some introductions from our Kaiser team. My name is Andrew Sang. I'm actually going to be presenting on behalf of Vanessa Davis, who's not feeling so well today, so just covering for her team. So I'm on the local engagement team. I'll get into the introductions in a second here, and then we'll just walk through a pretty good agenda. We presented this on Monday, but happy to be presenting here with the folks on for the Southern California counties, and we've got a slew of KP team members here who can dive deep into some of the following topics. So first, I'll introduce our KP humans at the top, and then we will do a little bit of an overview of Kaiser Permanente, as well as the latest MOU execution and implementation plan. And then we'll be passing it over to our child welfare liaison team to highlight some of the success stories, best practices, just how we plan to interact in the future, and then leaving some time at the end for discussion. And without further ado, I'll jump in. As you might notice, I'm not Vanessa Davis, but I am on the local engagement team, on the Medi-Cal policy and local engagement team. I'm a consultant serving a number of counties across the state. Ever since Kaiser Permanente Medi-Cal has expanded into the 32 counties, my primary objective has been to work with all the different engagement forums, such as the PATH collaboratives or other statewide associations, and engaging to make sure that we're able to represent KP and have the right community engagement in your backyards. I'd like to pass it over to our MOU team. I believe we have Roger and Love on the line for introductions.
I can start. My name is Love Nolichek, and I'm the MOU contract manager for child welfare and IHSS. And I actually have some background coming from DHCS. I was a contract manager there for some time. And prior to that, I worked as an IHSS worker for a local county for over 7 years. So definitely got to be on both sides. And I'm really happy to be here and to present to all of you. And I'll pass it on to Roger. Is Roger on?
Hi, this is Lana. I am Roger's counterpart in Southern California. I don't believe Roger's on yet, but in lieu of Roger doing his own introduction, I can give a little bit of an introduction of Roger while we wait for him to join here. So our team, Roger and I, we are part of the MOU implementation team, and we are responsible for the processes and the workflows and whatnot, and implementation of the MOUs actually after the MOUs are signed. And I think that's all I want to say. We will go ahead and wait for Roger to attend here, but gonna pass it over to Ola.
Thank you, Lana. So I'm Ola Ajibola Stott, and I am the Child Welfare Liaison for KP. I come from working with children in foster care as well as adjudicated youth across California, as well as I've worked to stand up a crisis program in Virginia, and I've worked with some of the indigenous populations in Hawaii. So wealth of knowledge of, helping folks to access care across a few different states. But I'm here as your child welfare liaison and joined by a few other folks on my team. We do have Ingrid as well as Phil from Kaiser Permanente. They are our regional center and IHSS liaisons. And then I also have two other team members. One, Andrea on the call, Andrea Arciniga. I know that you had a name change. And then also Gina will be joining us later on. Gina Annixter is our Director of Complex Youth for KP. And Gina and Andrea are both leading the foster youth model of care for KP. So they will join. Gina will join later, but Andrea is also on the line. Just wanted to introduce a few folks from my team on the call.
Hola, this is Gina. I'm on the call. Thank
Oh,
you.
perfect. Thank you, Gina.
Excellent. And then I believe we have Roger join as well. Thank you so much. Sorry for, I know everybody's so busy, but want to make sure that we brought, the KP team here, but on the slide here, we're just going to showcase the main points of contact. But yeah, I'll open up to Roger if you wanted to introduce yourself as well. I know Lana just did a great job of sharing your role and her support as a counterpart for the MLU implementation team. Excuse me.
No, thank you so much. Very nice to meet you all. Sorry for being late, and I think Lana probably covered everything. So looking forward to the conversation today.
Okay, awesome. Well, thank you all so much. Just really excited to bring our Kaiser Permanente team to bear here with our Directors Association. I'm going to jump into a little bit about Kaiser Permanente just to orient ourselves. So first off, Kaiser Permanente, the mission, right? It exists to provide high quality and affordable healthcare services and to improve the health of our members in the communities we serve, right? So with the introduction of CalAIM, I know it's a big transformation across the state for the 32 counties in which we serve. I think the big piece here to highlight is the community piece, right? As we're really learning and redefining, care is delivered in a community-based setting. And that's where our team, with the Medi-Cal local engagement team, having been a Medi-Cal provider in the community for many years, I just want to make sure that we're increasing our visibility within each of the counties, within all the various stakeholder groups, so we can ensure that we're serving the population together. So I think that's just a critical piece to emphasize that a lot of the work that I'm doing is engaging in the county level, and I think that's going to be a shift for Kaiser Permanente and some of the MCPs moving forward, but it'll be just, I think, the way it really needs to be. One aspect of KP2, I just want to make sure that it's a little different from other MCPs, is that, we are an integrated health system. So, just to orient again, we are a health plan and a hospital system and a provider group working in an integrated model. And as the folks here are all primarily KP Medi-Cal, I just wanted to kind of just make sure, there's some understanding of the team that's serving you here. A little bit about the direct contract. I know that as of 1/1, and many of you may already be familiar with this, but just as a reminder, effective January 1st, Kaiser has been providing Medi-Cal coverage via direct contracts with DHCS, right? So we had been providing through 5 counties and 12 plan partners in other counties, but as of January 1st, the plan partner counties have now transitioned into a new direct contract between the health plan and DHCS. So what that means is that Kaiser will be expanding to 32 counties this year. As of this year, this allows Kaiser Permanente to offer Medi-Cal coverage which matches our commercial footprint. Because as you know, people may come in and out of various health plan coverages. So, whether they lose their commercial coverage due to, decreased income or different eligibility criteria, this is just to make sure that Kaiser is investing in these social and health safety net, ensuring that the members, have continuity of service for all the Kaiser Medi-Cal benefits. And this extends access for Kaiser Permanente care, especially specialty care, to non-members in selected areas as well. So there's a lot of work happening, being invested in the community. And just wanted to note too, Kaiser Permanente's Medi-Cal plans are one of the highest rated for quality and equitable care. I just think it's just really good to orient folks to what Kaiser Medi-Cal can offer as an MCP. So moving a little bit into our footprint, right? So as I mentioned earlier, expanding from into the 32 counties, there's about 1.1 million KP Medi-Cal members, and we serve them across all 32 counties. I know right now some of you may be familiar with the Kaiser model of the Northern California and Southern California, but right now I want that make that relatively opaque to the people attending this call, in the sense that we want to make sure that Kaiser Permanente is able to serve and create a consistent experience and offer services to all our members across California. So I just wanted to kind of highlight that a little bit. So we currently offer commercial coverage, Medicare, Cover California, and then Medi-Cal in these areas. A little bit about what determines eligibility for a Kaiser Medi-Cal member, right? So I think a big piece of this is that, obviously this is driven by member choice, but, reading through some of the bullets here, right? Kaiser, as of 1/1/24, members are eligible for KP Medi-Cal if they've had KP coverage in the last 12 months, if they have qualified family linkages, so they have the family members, right? Those that are foster youth or former foster youth, right? It's very timely for this presentation here, where we're bringing to bear our child welfare liaisons and that department. But most importantly, that's a large population of focus for Kaiser Permanente Medi-Cal members. I think there's roughly 10,000 foster youth in the state, where we're looking to prioritize offering, Medi-Cal services, as well as those, who are duals members, right? That both have Medi-Cal and are, over 65 and qualify for Medicare. A little bit about what the direct contract means, right? So for those eligible beneficiaries who do not select like the MCPs, they will be default auto assigned to KP Medi-Cal in those 32 counties that we shared earlier. So that's just how the change that happened, I guess, prior to 2024. So as we see that, we expect Kaiser Permanente Medi-Cal enrollment to increase, throughout the next year as members get auto assigned to KP Medi-Cal. One other piece too, just to really make sure we clarify too around the qualified family linkages. A big part of that is spouse or domestic partner, children or under 26 years of age, disabled dependents that are over 21 years of age, any parents or beneficiaries, and then grandparents as well as and with the documentation of the family relationship. So that's a little bit more about our, I guess, membership. I'm going to jump into it a little bit here and share, with the CalAIM transformation, which I think most of you are already familiar with. We're going to talk at a high level quickly about, ECM, enhanced care management, community supports, and, one of the differentiators for Kaiser Permanente Medi-Cal is around the network lead entity model. So I'll breeze through like the high level stuff that you've already heard before, but I'll focus a little bit more about some of our differentiators for ECM, CS, and the network model. So as you all know, over the 6 years, I think through 2027, the the Medi-Cal managed care plans will assume an increasing role in managing the Medi-Cal population, right? So a big part of that is through CalAIM. It's a multi-year initiative through DHCS, aimed at, now I think they're rebranding it to call Medi-Cal Transformation instead of CalAIM. So if you guys see that somewhere, you'll understand that it's referring to CalAIM still. But a big part of that is that just making sure that what the MCPs are working on is contracting with and coordinating care with community-based resources and counties to not only address the medical needs of the population, but also the needs around the social determinants of health. So again, reiterating to it's going to be around managing member risk through the whole person care model, making sure that there's more of a seamless system, so partnering with our counties and community-based organizations, and making sure that the whole infrastructure and the system for transformation is building on that delivery system infrastructure, right? So making sure that the initiatives are aligned and the systems for payment, for data sharing, those are modernized. So that's a big part of the Medi-Cal transformation. As I mentioned earlier too, you guys are familiar with in this graph here, just showing the levels of care management that are being offered through Medi-Cal. As we know, we're going to be talking a lot about ECM and enhanced care management being one of the higher acuity needs, right? So for centering around the Medi-Cal member, with the highest acuity, they will have the opportunity for in-person coordination with a lead care manager through ECM. We know that they are also offered other levels of care management too, through complex care management and other just basic population health management initiatives. But the most personal and I think the largest piece of the transformation around the member focus is going to be in the ECM space. One part of that too, though, for ECM is that this includes transitional care services, so which are generally provided by the community-based provider. But this is regarding like discharges from acute care settings or other clinical settings into making sure that there's the safety net, right, to take on the cases for the member, right, so that offering different benefits and services. I think one of the primary benefits that we've been talking about is around community supports, right? So members who may or may not have ECM, they have a benefit for community supports, and we could share some of the 14 community supports later, and then as well as the community health workers, right? And the community health workers is more of a community partner benefit, right? Generally with practitioners with lived experience. This is mutually exclusive from ECM, but this is, again, just another benefit that's offered for the member care management. Some of that I know was may be familiar to folks, but I think what's important too is across the state, all the MCPs are working on increasing enrollment and utilization of ECM services. So not only Kaiser Permanente, but all the other MCPs, and really a mandate from DHCS is to drive up utilization of those services. So one thing that is unique to Kaiser right now that we're working on is prioritizing an outreach campaign pilot for driving awareness of ECM and increasing ECM referrals. So just to share a little bit for folks here on this call, a big part of that is planning a communications campaign and working with a public health communications firm, the Public Good Project, to identify key leaders and influencers in the local communities to identify how we can get members to be aware of ECM programs and increase referrals. As I mentioned before, right, and you all know this, that we can say it from like the state level or from Medi-Cal level, but really what's most trusted by people is the leaders in their community. So a big piece of that is with MCPs and Kaiser Permanente here working to identify the key stakeholders within each of your counties to help share some of the messages around ECM and target specific populations of focus to drive enrollment and referrals for ECM. So a big part of that is wanting to focus on the birth equity populations of focus. That's something that Kaiser Permanente is prioritizing statewide. And Kaiser Permanente is also prioritizing in pilot counties as well for Sacramento and San Bernardino around increasing referrals for child welfare and foster youth. So, the idea is that identifying members who are eligible for those ECM populations of focus, and then identifying the community providers and agencies that can help increase the referrals into those systems. And that'll be targeted later this year. So just wanted to highlight some of the work that we're doing here around ECM. I know I've been speaking for a little bit too. I think this would be a good part too. If there are any questions, I would welcome, stopping me from rambling too much or going off tangent, but would welcome any time where someone might have a question. I'm happy to open up for discussion. I see Diana, you have your hand up.
Hi, thanks, Andrew. Just on this pilot, our county child welfare agencies work very closely with a lot of community-based providers, and often they also know the trusted networks of community members. And so, just curious if you've engaged Sacramento County or San Bernardino County Child Welfare in identifying those trusted advisors.
That's an excellent question, and it's exactly what the point of the pilot is looking to do, because as the MCP, we're not in the communities as deeply as some of the community leaders, right? We're not at the churches where they are sharing awareness of these services for the members that need it, or we're not in the community centers where people are, driving referrals to utilize a lot of their Medi-Cal services. That's exactly the point of the program, to make sure that we're engaging with those child welfare organizations and identifying the right, trusted leaders who can help drive some of that the members to those benefits. And Ola, I see you have your hand up. I don't know if you have something to add to that or clarify too.
Yeah, if I can add that we did have a call with Sacramento yesterday, actually, with their child welfare department, and it was in collaboration with Full Circle Network. So I know we'll probably get into this a little bit later on who Full Circle Network is, but we were able to flash a slide on who our providers are. Some of those providers are known to Sacramento County, and I know that Full Circle has always, and including our local engagement team, has always welcomed, what's it called? Input on who else we could also partner with and contract with. And so we are currently having those discussions. I can also talk about that later on in my discussion. But that is the goal, is to ensure that we are talking to the child welfare departments and really sharing who Full Circle Network has partnered with, or who they have underneath their ACM provider network, and really ensuring that we're not missing any key partners in the community.
Yeah, Full Circle Health Network will be great. And I agree that they are in the communities serving folks. And we're happy to also connect you. If I see Adam Arneds, I don't know Adam, but from San Bernardino is here in the room, but their Jeannie Zapata is their director. So we can help with connections. Thank you.
Thank you so much, Ola, and thank you so much, Diana, for teeing up that question. I think that's a great example of how this meeting can be successful, is building on these relationships, building on the trust within the organizations as the MCPs enter in here, and making sure that we are doing it all for the benefit of the member, right? That's the whole goal of this, is that we're able to make sure that we're covering our Medi-Cal membership. So appreciate the opportunity here to kind of click in a little bit more and build some of those connections. And yes, I see a hand up from Susan.
Yes, I had a question in terms of community supports, especially in rural areas where we don't have a lot of infrastructure, and we may have identified leaders in that community, but they don't have the infrastructure to create that platform. So are you able to assist these local community members with creating infrastructure in order to drive, more enrollment?
Yes, no, thank you for sharing that. Actually, that's so, aside from presenting sometimes with these statewide associations, my primary focus is working through CalAIM initiatives and working within the communities too, at various forums with the Path Collaboratives and other forums, CalAIM work groups, where a lot of these providers participate. And a big part of that is using a lot of the programs around CalAIM, such as the incentive payment program or other funding initiatives. that we work with our NLEs to help build the infrastructure for those providers, right? A big part of that is like making sure that they have the right technical infrastructure to support processing, the referrals, making sure there's a closed loop referral process, for example, or ensuring that they are staffed appropriately in order to maintain, build the capacity to serve the KP membership in their service areas. A big part of that is working closely with the different CalAIM programs. So like I've mentioned before, incentive payment program. I know that there are PATH funds, and for KP and the role that I help serve is helping making sure that we have that process available open to those providers, as well as not only just creating the opportunity to help build their infrastructure, but really identifying the gaps and needs in the service areas. So earlier this year, we were able to conduct a needs assessment and gap analysis in the counties. So identifying various spaces where the infrastructure isn't built up. So investing more into those areas as well. Hopefully that answers your question, but yeah, that's some of the priorities that the MCPs are taking for building up some of those community supports providers and making sure that they have the capability to reach the members in their areas. All right, awesome. Any other questions around some of the ECM outreach or community supports as well? All right, I'll dive a little bit more in. Ola did a great job teeing it up to where we're going to talk a little bit about Kaiser's network lead entity model. So Kaiser Permanente supports the development of the community partner network with ECM and CS and CHW through what we call our network lead entities. So these are organizations that are, they have, and I'll dive into each of them in a little second here, but like a big part of that is that it enables a little bit more centralized coordination for building out the network while ensuring that KP retains oversight of the eligibility of authorizations, of member notifications, making sure that quality oversight is still controlled by KP, and any grievances. A big part of using this model as well is that a lot of these NLEs are embedded into the communities, and the expertise and services of the 3 statewide NLEs provides and ensures that Kaiser Permanente is able to provide a comprehensive coverage and enable timely access to ECM and CS and CHW services. And then finally, I think a big piece of that, as it's good to hear about Full Circle Health Network as well too. They have close partnerships with local CBOs to make sure that the right local providers and the right expertise are able to be delivered to the member. Click the next slide here. So that was just an overview of the NLE model. What is, I think, interesting to know is the 3 network lead entities that Kaiser Permanente has selected to work with here. Full Circle Health Network, obviously the theme of this presentation is going to be around child welfare. So Full Circle Health Network focuses on youth populations of focus, so children, youth, young adults, and families. And it's anchored, in California to build on existing relationships and just exactly what we talked about before, right? Finding the right community-based organizations and leaders to help drive utilization and enrollment into those services. We also work with other NLEs such as independent living systems. So this they're a long-standing community supports and enhanced care management provider, and they have a statewide presence, a large footprint across the entire state, as well as Partners in Care Foundation, was strong NLE organization, has extensive experience in that space, and they serve Southern California. A little bit more on, just the contact information for, if organizations are looking to contract to serve KP Medi-Cal members, this is the information here, and we'll send it out after this presentation. But, the outreach to, I think, identify interest into contracting to serve KP Medi-Cal members, reach out to these NLEs, and I think they'll go through a process for like a letter of intent and go through the initial assessment for provider contracting. And I see, Dana, you have your hand up.
Yeah, I'm very familiar with Full Circle Health Network, but not so much the independent living systems and partners in care. Can you share just any expertise they have with any of the populations of focus or community supports?
Yeah, so for independent living systems, actually, they are also a managed care plan in another state. They have a very strong state. They have a large footprint across California and working across multiple states and CBOs. They do have extensive experience, partnering with CBOs, so they have models around that. Right now, what's beneficial too is that they have very strong, technical infrastructure. Right, a big part of this where we're seeing, I guess various capabilities of providers is being able to offer a lot of those key pieces around the delivery system infrastructure, right? Making sure that they've got the right systems for referrals and auths, making sure that they've got the right systems for payment and claims, right? So being able to scale that for some of the providers is a key differentiator, I think, for independent living systems, ILS, as we call them. Another part for partners in care is that they do have very distinct experience serving high needs members, so very high acuity cases. Um, in, Primarily based in Southern California, they're going to be established to serving local community-based organizations. So that's a big piece of that there. Um, and one of the things I think that's really important to highlight is how Medi-Cal services access outside of ECM are focused. So a big thing is that you don't necessarily need to be enrolled in ECM to take advantage of community supports. So a big part of that is just building on the supportive care through different programs in that space.
Thank
Yeah,
you.
and more to come to. I welcome to. I know Full Circle, for example, has office hours. You can also reach out to us too to help get you directed to the right NLEs so that they're able to share more detailed information and they can talk a little bit about their value propositions as the NLEs. And Ola, you have welcome if you had anything you wanted to add as well.
Yes, just going to try and come off mute, but essentially we are referring all of our child welfare and foster youth are all going to Full Circle Network. So there may be a few onesie twosies here within ILS or Partners in Care, but essentially we are using or we are deferring to Full Circle to really wrap their hands around all of our foster youth and child welfare involved youth. I know that ILS, they are taking on our JI population, so justice involved. So that's another little key point to make as well.
Excellent. Thank you so much for adding that. Yeah, that's great experience too that you're sharing directly how we're working with the NLEs. So moving through this, just the last piece here, right? There's Kaiser Permanente in terms of referrals takes a no wrong door approach. Just trying to be mindful of time here. I'll just kind of talk through it a little bit. What this means is that referrals are accepted from any source. So you can download our the Kaiser Permanente referral form and send it to the email with the request for a referral. But if you don't have that form, that's totally fine. Working with all other MCPs. The forms as well. So taking the no wrong door approach that can accept it from any source, right? So members, providers, family members, things like that. And they can be done through email or phone. One other thing to note too, and this was a question asked in the previous meeting, is that we do partner with other MCPs to create joint referral forms. So in counties, I think in Los Angeles, Sacramento, Stanislaus, and San Diego, I think partnering with the local MCPs in that area to make sure that there's more of a unified referral form structure there. All right, and then just moving through here, just wanted to highlight just a slew of Medi-Cal resources that we want to offer. This will be sent out again after the presentation here, but I think just very important as we're orienting ourselves to, Medi-Cal transformation, formerly Cal-AIM, and making sure, if you need to identify, things for continuity of care, or I know the redeterminations happened early last year, but questions around eligibility there, these are all resources to help support that. All right, without further ado, I'm going to pass it over to our MOU team. I believe we have Roger and Lana on the line, and Love as well to be able to share a little bit more there.
Andrew. So everybody, for this section, we'll plan to just cover, I think a lot of what your teams have probably interacted with Kaiser. We'll go over the execution process, signing the MOUs, and the implementation process in terms of like what to expect once the MOUs are signed. So again, like Andrew mentioned, I'm joined by my colleagues Lev and Lana today, so we'll go through a couple of these slides with you all today. Can we move to the next one, please? Thank you. We're actually going to progress. If we could do 3 clicks, since a lot of this is a retread into, with Kaiser assuming the, functions as a managed care organization, kind of taking over those MCP responsibilities. Again, maintain those relationships in those 5 existing GMCs, as well as transitioning into a direct contract for those 17 plan partners and moving into 10 new to KP counties. What the intent of this journey to today's slide is really to demonstrate and show that, from a resourcing perspective, Kaiser has wanted to take a very intentional approach to making sure that your teams as our partners have the right resources and support as we embark on this sort of next phase of the work. If we could progress to the next bullet, please. Thank you. A little bit about kind of the model that's been set up. What internally at Kaiser, what we refer to ourselves as is the MOU work group. So that's where all of the different pillars of our teams that you see today are represented. Our team is covering the operationalization components, so thinking about the MOU coordinators that we have on the call today as the folks who will be your forever person post-execution. All of our coordinators are assigned by counties, so then they are going to be sort of dedicated to 2 to 3 counties once we're at full staffing, and so they would be sort of your go-to person across the board and kind of your primary point of contact from Kaiser for sort of any programmatic issues or questions as it relates to, in this case, the child welfare MOU. During the execution process, during the signing process, this is where you'll meet once I give Love a chance to talk. Love is our contract manager for child welfare, and so she manages the execution process going through the red lines and everything. And then in terms of where we're at today, we continue to make outreach to our county and county agency partners, making progress towards execution. We're continuing to onboard new team members to support this body of work as we prepare for this joint steady state operations. Then we can progress to the next slide. And so Love and I will kind of split this slide where we'll go through just quickly like objectives, and then the images that you see in the center of the slide, those are the 9 MOU types that will be executed and operationalized across 32 counties in California, mirroring what Andrew presented earlier about about Kaiser's Medi-Cal footprint. Again, kind of grounding us today in terms of like the scope and objectives for the MOU. Ultimately, Kaiser prioritizes collaboration and seeks to establish, these mutually beneficial agreements through these MOUs. This will ensure that we're aligned with both the HCS requirements while allowing us to make sure that we're building sustainable, efficient post-signature processes and implementations, and that it becomes, a true partnership between Kaiser and each respective agency. I'll pass it to Lev to go through the objectives and the teams.
Thank you, Roger. So what are the objectives that we have for the MOUs? It's to clarify roles and responsibilities between the managed care partners and third-party entities. It's to support local engagement. It's to facilitate care coordination and information exchange for referrals. And finally, it's to improve transparency and accountability for service and care delivery. So who are the KP teams? The KP teams include the MOU contract management team, the program liaisons team, the MOU implementation team, which are the MOU coordinators, and finally the PMG partners, who are the medical group clinical teams. Next slide, please. Next, we're going to talk about the MOU execution. And we're going to talk about the work group roles, and I'll talk about the MOU contract manager roles. We as contract managers, we manage contract negotiations, red lines, approvals, and signature execution. We report to DHCS on quarterly updates. And then post-execution, we as contract management team, we manage contract storage. We post for DHCS reporting, and also we do the ongoing maintenance of the MOUs. And I'll pass it on to Roger to talk about other responsibilities of our MOU team.
As I was mentioning earlier, the MOU coordinators will be the individuals. A couple folks are on the call today that I'll shout out in a little bit, but they're the individuals designated by the MCP responsible party as stipulated in the MOU. They're the contractual MCP liaisons in all these MOUs, so they will serve as your primary point of contact into KP to really serve as that bridge between as we enter into these partnerships with the MOU. Once the MOUs are signed, sort of post the execution. They will lead the implementation and operationalization in partnership with your teams. Our team operates as a subject matter generalist. So thinking about, post-execution, they'll be the ones helping to facilitate the quarterly meeting or whatever frequency makes the most sense for the county and agencies. And then managing the ongoing relationships to make sure that, once we're in that steady state, we're able to properly, address any programmatic risks or concerns. And if there are any changes to the MOU that may occur. As part of this again, we sit as sort of one leg as part of this overall work group table, thinking about some of the folks that we have on the call as well, our program liaisons, Ola, Ingrid, Phil. They really partner with our care delivery operations implementation leads. Their scope of work really exists outside of just the MOU. They're really the subject matter experts in their respective domains, and we lean on them heavily again in this team-based model. We also have our PMG partners. So these are our medical group thought partners. These are clinical subject matter experts who, again, will be the ones working with your respective care teams to ensure that ultimately when we develop care coordination workflows and the operational processes, or PMPs as we're calling them, that we ultimately are able to make sure that we do ensure high quality delivery of care in this process. We can progress to the next slide if that's okay.
And I'll talk about the KP MOU execution and what involves. So before the MOU is signed, MOU contract managers at KP will collaborate with our external partners through the MOU scope, which is basically to define collaboration purpose and scope within all parties to begin this collaboration. Then we have the MOU kickoff, which is basically the meeting or kickoff discussion with all parties to begin our MOU redline discussions. Then we go on to the MOU red lines. We draft, revise, and finalize MOU terms with all the parties in order to move it towards execution. And then we also address requirements, changes, and establish amendment process. And finally, contract managers are specialized by the MOU type. For example, child welfare, IHSS, WIC, LHD, and so on and so forth. And now I'll pass it on to Roger.
So just wanted to kind of break out the roles and responsibilities for our team in terms of the MOU implementation team. So you all heard from my counterpart, Lana. She covers the Southern California region, and we have a couple of our MOU coordinators from the South on this call as well, Melissa Gonzalez and Giselle Fernandez. And then we have our Northern California team on as well, Emily Arienza, Victoria Navarro Gutierrez, and Kate Goriette. And a little bit in terms of like what our team does, right? Thinking about it as like, post-execution, serving as your primary point of contact. It really is as they operate as subject matter generalists, focusing on training development. So we'll be able to provide, initial MOU training materials to serve as an iterative collaborative approach. We see this as a broad introduction to Kaiser. We also don't see training as sort of a one and done type of effort. I think that's going to be quite rare where we're going to come across instances where that does work. But within 60 working days post-execution, we will provide an initial training deck that will sort of kick off the process, as it were, to begin this joint approach. For workflows and processes, we are going to be the ones to help connect all the stakeholders across both parties through these discussions to ensure that we are defining the right instructions and policies and procedures to be able to execute this effectively. Establishing quarterly meetings, this goes back to the basis of the MOU, which is really building a way for us to maintain the sort of continuous collaboration and communication. Like I said, ultimately, the MOU coordinators you and your teams will be working with are assigned to specific counties, ultimately about 2 to 3, and they will be your centralized points of contact post-execution. I think we can go to the next slide. And I think this is back to you, Love.
Thank you so much. And then we'll talk about the phases of our MOU process. So phase 1 is when the contract manager schedules the kickoff meeting. Then the contract manager maintains execution tracker, leads the MOU redlining, manages county MOU correspondences, obtains SME and liaison feedback, and sends to the legal for material changes. At this point, all parties agree when the MOU is ready or not for signature. This process also involves counties sending it to your stakeholders, to your legal team, to your SMEs as well to get their feedback. Phase 2 is contract manager identifies MOUs ready for signature and prepares necessary documents to submit it. Contract manager submits the pre-signature memo to signatory, and contract manager facilitates the briefing meetings and sends approval MOUs for signature via Adobe Sign. And then finally, phase 3 is the implementation of the MOU. Contract manager stores executed MOUs and related legal correspondence for future references and plans for annual updates that we do every single year. Then contract manager team files executed MOUs with the DHCS and posts to kp.org. And finally, contract manager hands off the MOU to the MOU coordinators that we have, who schedule quarterly meetings and maintains the ongoing relationship for the city state. Next, please. And now I'll pass it on to Ola, our child welfare liaison.
Before I get started, any questions? All right. So again, I'm Ola Jibolista. I am joined by, as far as child welfare, I'm joined by Andrea Rogers as well as Gina Annixter. So again, I want to preface this by saying that, that we are finding new ways to engage our child welfare and foster youth population. So there is a lot of building happening, and as our my colleagues Roger and Love discussed, we are executing MOUs, and so we are in beginning stages, and we are looking to really wrap our hands around our foster youth. So a lot of development happening behind the scenes, and I think that our current state will inform our future state, right? So I do like to flash this slide, so I do think that we need to kind of ground on who are, and I think it says foster youth, but really child welfare involved youth, who is really at the table. And so so we can stay grounded and connected as an integrated team. So to our top left, we have our county public health nurses, our behavioral health, whether it be our county or our community organization. We also have managed care. So I'm on the managed care side as a foster youth liaison or child welfare liaison. We also have, in some instances where there are assigned care coordinators on our health plan side. And then we have our healthcare. So we have our medical groups assigned to some of our medical offices. We have some social workers and nurses that are assigned to some of our complex youth and some of our high needs youth. And then we have our community organizations, schools, courts, and then last but not least, our county social workers. So again, I think future state, we need to stay kind of grounded and connected as an integrated team. Although we are not there yet, our foster youth model of care, as well as signing these MOUs and our contracts, will hopefully get us to a point where we are all connected, especially around our child welfare involved youth. Next slide. So I'll kind of get into what my role has been thus far as a child welfare liaison. So at the top, I do engage locally. I sit in our collaboratives. I do attend the quarterly statewide task force with all the counties are involved. So I do attend those. CalAIM collaboratives, and then I'm also at the table for our child welfare MOU discussions. To the right, we have issue resolution support. So this is where the fun happens. So all of the different counties have my information. So my phone number, as well as my email address. And so social workers and public health nurses have been contacting me due to change of addresses, ECM eligibility and enrollment, Kaiser enrollment, updating legal documents, obtaining medical information, scheduling appointments, a lot of right futures concerns. And then drops in medical coverage. I did get last week a JV 220 physician statement that needed to be, received on Kaiser's end. There were some back and forths happening there, so helping the public health nurse to get that to the right people, and then validation of coverage. So, and the list has gone on. Last month, I helped one of our Northern California partners that you guys might know. Carol Brown. She had one of her members was experiencing a medical emergency in the Middle East, and so I had to find some medical care in their while they were laid over in New York. So again, some of these are more dire, more urgent, and again, sometimes it's just kind of connecting our county partner with the proper resources, because I know that systems can be hard to navigate and access. And then to the left, we have care coordination and care delivery. So I am collaborating with internal and external teams to execute referrals and help schedule appointments. I've also been helping with ECM authorization and service coordination. And I believe, and I put this on the bottom, I believe that above all, I am the family advocate. Although I'm not really family facing or a member facing, I'm here for the family unit. So that's in a nutshell what I've been doing. Do we have any questions before I move on? All right, next slide. So then I have two member stories, and these are real life stories we've taken out identifying information. So the first story will be an internal member story, and then the second one will be a external from one of our partners. And so this first story I'll walk through is we had an internal referral from one of our child abuse pediatricians. And so this family was 3 African American siblings that were experiencing housing instability due to the death of a family member. Sibling 1 has suicidal ideation, untreated ADHD, poor dental health, uncontrolled asthma, and she had adapted the parental role. Sibling number 2 had unaddressed swallowing dysfunction. 3 suspected delays and suspected hearing loss due to trauma. I did want to note that this family came to us with having previous KP HMO coverage, and then they were placed in foster care, and the foster mom was Spanish speaking only, and the foster father spoke English but was worked daily in Home by 5. So just kind of setting up the story, and then I'll walk through the steps that I took on the next slide. So again, because this family was previously KP, but then again removed from their home environment, they were switched to fee for service, and so I did help this family enroll into KP Medi-Cal. So the county already did submit KP enrollment through the state system. So I called the DHCS ombudsman to help facilitate an enrollment as of the current month. And I want to preface this by saying that, again, we are learning from our processes. And so, again, this journey may not be a journey that we're going to take in the future. We're really starting to put together those processes. But this is the journey that I took. This is the steps that I took in this particular scenario. I did meet with the CPS social worker who had no idea what ECM was. And so I wanted to provide some education to that CPS social worker so she was able to understand what the benefit was, and ensure that we would be working with in collaboration with her on the family's needs. Then I had a cross agency team meeting. I scheduled and facilitated a meeting with our child abuse pediatricians team. I brought in Full Circle Network because we wanted to review the case and to ensure that we had the proper lead care manager assigned to this particular case. Then I worked to enroll these 3 members into enhanced management services. That was more of an internal process for me. So I got the 3 kids authorized for ECM. And the next step was I had a case conference. So I initiated a case conference with our newly established team. So we had a county social worker, a Full Circle Network. We had the newly assigned lead care manager who is Spanish speaking. And then we had our KP team that was on the call. And so we want to provide as much information initially so that it's able to inform their assessment. And then we made outreach to the family. CPS worker was contacting the family, as well as our child abuse pediatrician team reached out, so they kind of got the information from both ways, because what we do want is to have a successful outreach attempt. That's really where we're struggling, is really how do we get our families engaged. So we felt like, having those 2 avenues would be beneficial, and it was. And then we had our first progress update. And all 3 siblings had been linked to, sibling 3 was linked to audiology and speech therapy. Sibling 1 and 2 had intakes completed for counseling. And so that was pretty much at a high level, the steps taken. I do want to report, because I was able to get some information as to how this family is doing. All three siblings did transition back to the biological family. It was a little soon. But we wanted to make sure that this family was continuing to receive enhanced care management services. So that was one of the constants outside of our county partners. We had a lead care manager that not only was working with the foster family, but now is transitioning that work to work with the biological family. And so that particular lead care manager is still making home visits. So she's visiting the family every other week, and on off weeks, she's still calling the family for her check-ins. The birth mom is receiving two types of services to include voluntary parenting. Dad, who was previously disengaged, is currently engaged, not only in our enhanced care management services, but also he is engaged in anger management, and he was the aggressor in this situation while the kids were removed. All three children are receiving counseling and therapy services. All three children are enrolled in school for this current year and are linked to community programs for educational support. And our lead care manager and our social worker are in close collaboration. They are engaging via email or phone conversations, even outside of KP, and they are pulling in KP as needed. The voluntary services are, I believe, county driven. Any other questions before I continue? Awesome. So this is our second, oh, sorry, Susan.
Yes, I just wanted to share that I think that it's amazing. I mean, you're going to work child welfare right out of business. I really, really liked your understanding of child welfare and what our specific needs are. I wanted to see if you could speak a little bit as to how how did you connect with child welfare? Like at what parts of this process did you make that connection?
A really good question. Because it was an internal referral from one of our uh, child abuse pediatricians, they are usually engaged with local law enforcement or CPS workers, and so that's easier for me to identify who is on the county level. It is a little bit more of a struggle when it's I just have a list of all of our foster youth, or and I don't have who was assigned to them. So right now it's very manual. I'm researching on county websites, or if I'm already linked to the county via those MOE conversations, one of the asks is, who am I partnering with on the county side, so that we can ensure that when we have these kind of scenarios, that I can partner with that person to identify who is the CPS worker or the child welfare lead, the child welfare social worker, who is a part of this child's team that I can tap into. So right now, I think it's a work in progress. I think that future state, once we execute our MOUs, I will have my partner in each different county, so I can ensure that I have a person to connect with. Some counties are sharing their rosters with me, but again, if I just have the child and I don't have their assigned county worker, then it's hard. I have to have some type of point of contact to actually identify who's actually working with that child or family. Did I answer your question?
Yes, you did. Thank you so much.
You're welcome. Diana?
This actually ties into my question. So, Susan, thank you for the lead in. It was perfect. And Ola, this is such a great case example, and thank you for supporting the kids and families in this way. Carol Brown, actually, you mentioned her name earlier. She's kind of famous in our circle. She's a public health nurse extraordinaire, and leads and is a liaison to a lot of the foster care nurses across the state, which I think to your challenge there in terms of finding the social workers if you need to. Like, actually, they could probably be very helpful to you if you were to reach out to the public health nurses. But they also do some care coordination, right? Healthcare coordination. So I just wondered if you could speak to your experience or how you, or your vision, maybe it's two things, of the role of the public health nurses that are assigned and funded by the state to do healthcare coordination for foster kids.
It's more, when it comes to enhanced care management services, specifically, it's more of a collaboration on how do we, and sometimes it's going to be more in, sometimes we can see it more beneficial to some of our preventative prevention, like the family maintenance program families. But essentially, it's more of a partnership. And I know that we are getting to a point where our lead care managers will have access to some of our internal information. So such as like, I know that our public health nurses need to manage the health passports. And so understanding their last appointment, ensuring periodicity, these lead care managers, I'm not sure if all public health nurses are meeting with the families in person. I know that in some counties, it's 0 through 6, they have home nurses, but not sure about all counties. But essentially, lead care managers can, help families in home make appointments and ensure that there's appointments made. So as far as lead care manager, that we see it that way. For me, we're trying to connect with the public health nurse to ensure that, we have that they have all the information that they need related to navigating their healthcare needs. And so there has been some questions as to, did they attend this appointment, immunizations being missing from records. And so as far as my role has been, it's just ensuring there's no glitches in the system. But it's more of a collaboration in that way. And bringing in those parties to have those discussions if there is a public health nurse assigned.
Thank you. Yeah, and I realize that there is some differentiation across counties in terms of what PHNs do. Some more robust set of services than others, and so I'm sure that's a little difficult to navigate for you all. But something that, I think they are a good point of entry if you need it. At minimum, a point of contact, as you're saying, to get information, or two, if there's a gap, and they could be your partner in terms of supporting the family. You had also mentioned, I have a part two of my question unrelated to that, which is when you engage the social worker, they didn't know about ECM, which we realized that to be the case, not unsurprising. Or not surprising. KP, do you have training that you're able to do on ECM and linkages, and have you done that yet?
We do, and I actually am going to talk about that in a future slide. We are doing road shows, and I'll kind of dive deeper into that, but there is training that we're trying to do, and it's specific to child welfare. It's not just a general overview. So I will talk about that in just a few minutes. All right, so next slide. So this is the external case that I got. So this was from one of our public health nurses, actually, a 5-day-old born in the county hospital, removed from mom's custody. She was automatically enrolled in Medi-Cal fee-for-service. The foster parent, who was the maternal uncle, lives 2 hours away out of county, but all follow-up care appointments were scheduled in the community clinic where the child was born, the baby was born. The foster parent is a KP a KP member, and was seeking assignment for a KP assignment for the child, so that he can access care as he normally would for himself. And then this baby needed urgent follow-up for labs, as well as newborn well visits. Next, I will talk about the needs that identified. So I needed to enroll her into KP Medi-Cal. We needed to find her local pediatric team. We needed to ensure that her labs and well visits were met. And then I wanted to ensure that we had a well-coordinated, integrated team. So first, I was able to get the baby Kaiser MRN. So I called our member services to obtain a non-member MRN, and I verified that this baby had a chart. So then I then coordinated with the county public health nurse and the family to understand where they wanted to access services and visits, and then we also obtained our report documents. Then I called our appointment line to schedule an appointment, and I emphasized the need for the labs. And then after that, because I need to ensure that I knew who our team, our medical team was that would be seeing the baby. We started a group chat internally to be able to share information with the doctor and the medical team that would be seeing the family. Just giving them a little bit of a heads up and sharing any information just so that they knew that this was a foster family that had some very urgent needs. And then I had some post-appointment messages exchanged by the provider. So after the appointment, the provider was able to update me, and I was able to update the public health nurse and also link the public health nurse to the treatment team. And then we did have this is just more of a note, we did exchange information and sign some releases for our internal and external folks. And then, sorry, one last thing on the last slide. And then, I actually mentioned this in the last box, but we did have an internal external collaboration and exchanged information because we know that the public health nurse needed some information for her health education passport. On the next slide, thank you, Andrew. I'm just going to give you guys just some outcomes from this story. So the newborn had follow-up visit scheduled within 24 hours with the new physician. I did put her appointments and encounters that we had scheduled as a result of this linkage. And then because we did have a general, we linked her initially because we knew that she needed to be seen right away with a general practitioner. I was able to get her assigned to a pediatrician, and then both the general physician and the pediatrician were linked and were able to share information. So there was no gaps in her information there. And then we successfully completed the KP medical enrollment. Her newborn medical records are centralized. Public health nurse has been looped in for all updates. And then the more recent update that I got earlier this week was that there is a physical therapy assessment that is currently being scheduled. So again, from start to finish, we have a baby that has been linked to KP through various steps. But again, everything that I'm doing is informing both Gina and Andrea, who are leading the foster youth model of care, because we are looking to do things better and to really ensure that we have a system and a process in place for us to seamlessly navigate our child welfare and foster youth. Next slide. These are just this is just some recommendations from me, just based off of just some of the escalations that I've gotten. So when it comes to me that we need a child that needs to be enrolled in KP, it is helpful that we've confirmed medical eligibility within healthcare options or the AVE system. It's also helpful if we can confirm that there has been an MCP selection of KP, and then county partners can also retro enroll or call the DACS ombudsman to have the family retro enrolled into as of the current month. And then if there is assistance needed, I did put my information there, but it's also helpful for me to have their CIN number, name, date of birth, their address that's on the medical application, because if I called the state, they will not give me any information if I don't have the most recent or whatever address is on the application, and then phone number. And then I also added some to the right, just some helpful information and helpful contact information and notes as to when we would use some of the contact information. Yes, Diana.
Two questions. One is on that retro enrollment. We have kids, as you know, that move counties. And so you may end up having a kid come into a KP catchment area from a non-KP county. And so can you do auto enrollment if they're coming from a health plan in another county?
Do auto enrollment?
Yeah, the retro enrollment. Sorry, the retro, not auto, retro enrollment.
Retro, I mean, it can. I mean, it just depends on. So essentially, what happens with enrollment is, I mean, I might be speaking to the choir, but when the application is submitted, if it's submitted by the 20th to the state, then it would be active as of the next month. If it's after the 20th, it would then go to the following month. And so essentially, what we're doing is trying to get them enrolled as of the current month, and that's what that's doing. And so if they get it in within before the 20th, they would just make a call to say, hey, we'd like them because of the need of specialty services, specialty care. We want them to be enrolled as of the current month.
Perfect. Awesome. Thank you. And then just a second question, because I saw it on your slide on the releases of information. Any issues so far you're encountering that we should be aware of that we could
Not yet.
Okay, cool. Great.
Not yet. Hopefully not ever. So next slide. All right, so I think this is what you were talking about, Diana. So we are offering ECM and child welfare presentations. So I am partnering with Full Circle Network and our local engagement team, so Andrew's team, to deliver these conversations across counties. It has been a staggered approach, just from the counties that, you know, their comfort. And so I know that we have I believe one of our partners from San Diego is on the call, but we have completed San Diego, Orange County, Riverside, Imperial. Sometimes it's with just the leadership, and then they will, you know, next steps would be with a broader team. We are offering to have the conversation as a bigger team, you know, with, you know, whether it be with child welfare, social workers first, and then maybe with the public health nurses second. But we are deferring to the counties to decide what feels best for them. And for the most part, counties are asking that we talk to their leaders first, and then they'll let us know when we can kind of have a bigger conversation. As I mentioned, this just happened late yesterday. We had a Sacramento call yesterday. So Sacramento has been scheduled. We have two calls scheduled for Sacramento. We had the first one yesterday with their, I think, pre-court social workers. And so we had a user story, like a family maintenance program user story, that we walked through specifically what services, not only for the child, but also for the family, that we would engage based off of the family's needs. And again, we have scheduled Sacramento, Yolo, Sonoma, Santa Clara, Solano, Santa Cruz, San Bernardino. I just was able to schedule yesterday, Contra Costa, and I do have a few that are pending. And the goal is to have these conversations with every county. And again, we're deferring to them for feedback on how they'd like to roll them out. And essentially, I think future state would be, how do we incorporate this content within onboarding for the county? I mean, do we want to add this to the toolbox of our you know, social workers and public health nurses? Is there any kind of, you know, training that we can provide to, you know, I don't know if there's like a university, or, you know, I'm not sure how the trainings are structured within the different counties, but can we incorporate trainings on onboarding the staff in the different counties? Or even ongoing training, just to kind of ensure that we know that this is a toolbox item that they can pull from whenever needed.
Yes, I mean, to answer your question, yes, and we're thinking along the same lines, so I love this. We have a social worker academy, and like, for example, LA, who they have their own training system. So, and then otherwise we work through some regional training academies. And so I very much agree that this should be, and we should look to the future of you know, as social workers on board, or they're renewing their training because they have a renewal that they have to do on their training. And I'm glad to see that this is happening. Also, just so we also talk with Full Circle Health Network. I know Camille Schrader. I've known her for many, many years. And so we're looking at, like, how do we partner and support the work? And it's a little chicken and egg, just so you know. And I think this is why you're doing the training to directors first before staff, because, you know, the child welfare population is so you know, your prior slide on the core team was really illustrative of the fact that they are touched by many systems and different entities. And so issues of trust and understanding before acceptance of services, like, we want to make sure we're thoughtful around that work before we do that engagement, and be very thoughtful with you all on how we engage families, so we're not overwhelming them or scaring them off, so that they're more accepting of services. I think this is a really great complementary service that Kaiser and other plans are offering through CalAIM, but we just want to be very thoughtful on how we implement. So that we're trying to do the dance, right? And it's a very
Right.
difficult dance.
Right, and
But
that's a great point, Diana. So,
yeah.
and I think so. If I can just note, like county like Sonoma County, our next steps is to I'm sorry, Sonoma County and other counties, but a next step is to like we're calling it a pilot, but how do we let's walk through a few cases first and walk through the process and to ensure that there's a process that we can kind of um, roll out to the team. So I agree. It has been a process, and we're here for that process. We make sure that it is as seamless as possible, and it's not received as an additional piece of work or duplication. So we definitely want to be systematic and strategic with our approach here. Thank you, Diana. All right, next slide. I know I'm running a little bit over. So next steps, we're going to continue our county conversations and to include all KP's Medi-Cal services available for our child welfare population and their families. We are working to, quick identification of county social worker and public health nurses. And this is not an exhaustive list. I think there's a lot of things I can add to this list, but this has just kind of been my next steps right now. But also reviewing our foster youth aid code assignments with counties for strategic next steps. And so we, like for example, Sacramento, I was reporting yesterday that they had about 1,300 foster youth. Well, how many of those foster youth are AAP versus relative caregiver? So, we want to be intentional because we want to make sure that we know that there's probably less frequent touch points with AAP, and maybe some mailers or some training that we can give to those assigned social workers that work with those families, but be more strategic and intentional about how we're delivering the message to our families. Along with data sharing, and there's so many things that we're working on as next steps. I believe this might be my last slide. Yeah, my last slide. Perfect. Thank you.
Awesome. Well, I'll just pause here really quick. I know, and I'll take this down because I think benefit to seeing everyone's faces too. But welcome the time to open it up for questions and discussion. It was great to have the opportunity to be interactive during the presentation too. I think that was a very good thing to do for this presentation. But would love to pause here, take down my screen, and open it up for any questions for the Kaiser Permanente team.
Dr. Lau, would you like to go first?
Hi, good morning, everyone. Thank you so much for this presentation. I really appreciate your approach and your thoroughness when it comes to the child welfare population. I was privileged to speak with Dr. Cullen and Dr. Horton about your Quality Improvement Health Equity Committee and the sort of preparation that you guys have done in the past couple of years for this launch. And I want to thank Ola for all that hard work and just all the many, many, many steps and many hoops that she's gone through to help our kids. And I just really appreciate this approach and this partnership. Can you talk just a tiny bit on the auto assignment to KP Medi-Cal?
Sure, I can cover that. And thank you, Dr. Lau. And I'll pass on the words of affirmation to Dr. Horton and Dr. Cullen. We work with that quality team very closely too in our QHEC committees, and glad to hear that those are being well received. As to the auto assignment piece, so as per the direct contract, right, prior to that, Kaiser Permanente Medi-Cal was a plan partner or working in what we call the GMC counties, like the geographically managed counties, and providing Medi-Cal services, in those counties specifically, without through a partnership with other MCPs. With the auto assignment, effective as of January 1st of this year, that means that Medi-Cal beneficiaries who do not select a Medi-Cal plan will be auto-enrolled into Kaiser Permanente. And that auto-enrollment is generally based on, actually, there's an algorithm for capacity, right? So it's not just everybody by default gets KP. It's based on like capacity within that county and the Medi-Cal like provider network. So that's a big factor in the auto assignment. So KP is one of, as a direct contract provider, Medi-Cal provider in those counties will be I think the default enrollment, but it really depends too on the capacity for the MCPs. Does that help answer your question? Thank you. I see another question.
Hi, my name is Bo. I work in Ventura County for Children and Family Services as well, and very similar question just posed. For Ventura County, is that current system of auto enrollment happening? Or like you'd mentioned some stuff of pilots, but some stuff just right now that there is a direct contract. So I was a little confused on, is that happening right now or is that in the future?
No, that's happening right now. So as of January 1st of this year, so that's when the Medi-Cal direct contract went into effect. And I think it's based on yeah, again that eligibility criteria. So is the connections to KP and the qualified family linkages, as well as the other I think eligibility criteria for that. So based on beneficiaries that qualify for Medi-Cal at the beginning of the year, if they hadn't selected enrolled into a plan, they get assigned to that. But that had been starting as of January 1st.
Okay. So that is that only at the beginning of the year? It's not each month it's happening. It's only on January.
Yeah, so I think what happens is as members, I think, become eligible like throughout the year. It's not just like as of Jan 1, but throughout the year. So you would expect to see the KP Medi-Cal membership increase each month, and that's what we're seeing is
Okay.
we're seeing volume increases in enrollment as people become eligible for Medi-Cal.
All right, thank you. I appreciate it.
Yeah, thank you. Yes, Baljeet.
I'll let Susan go first.
Thank you. Just in terms of the automatic enrollment, I believe that they are automatically signed to the managed care plan, but that does not necessarily sign them up for the enhanced care management. Am I correct in that?
That is correct. So enhanced care management. So for example, there are members that we've heard where they're already in, for example, CCM or like a lower acuity of care. Actually, let me flash this slide up since I control the slide anyways, might as well. Here we go. Where they're getting case management or complex care management through other sources. It's actually up to member choice, and that's the benefit I think too through CalAIM, right? So we don't want to take away someone who's been working with a trusted relationship through a care manager and receiving services, and say all of a sudden you have to work with an ECM lead care manager instead. So it is driven by member choice. Hopefully that answers your question.
Yes, thank you.
Okay, great.
Yes, and this is Gina. If I could just add, can you hear me okay?
Yes, Gina.
Because our foster youth or youth that are in this population are a population of focus, right? So the child welfare is a population of focus. All of our folks that are in or members that are in this population of focus are automatically referred to our network lead entity, which in this case for this population is Full Circle Health Network. So I want you to know that we use those 8 codes and we do our due diligence by sharing those patients so that they can be enrolled. And of course, the hard part is the connection after our NLE makes the connection, tries to make the connection, if you will, with a family. After they agree to enroll, that's when we re-enroll them. But because this population is all eligible for ECM, we've done our due diligence to share the patient files in hopes of our NLE connecting with the families and enrolling them in ECM. Thank you.
Thank you so much, Gina. Let's see a question from Diana or Belgi. Sorry, I didn't know who was coming next there.
Yeah, no worries. I'll go. So this question came to us after the Northern Region presentation on Monday around, Ola had stated she was the only child welfare liaison currently for Kaiser, and knowing that Kaiser is in 32 counties. What is the plan moving forward? Is there a plan to hire more child welfare liaisons statewide? If you could speak to that.
This is Gina. I definitely can speak to that, right? We're just diving into this as quickly as we can and learning the extent of the need and understanding that one liaison may not be enough. We also have multiple new liaisons for other work as well. So what we're doing is starting where we're starting, learning what we're learning, seeing, there are many systems that we have to set up. So right now, Ola spends a lot of time on educating both internal and external partners, working with the network lead entity, helping to increase the ECM enrollment, as well as helping to ensure that our members get what it is they definitely need. So we do see that having additional liaisons is something that we're going to need. We are doing our best to comply with all of our requirements that are on our MCPs, and we acknowledge that we'll need additional support. It is important to note that we have an extensive group of social workers and nurses that we call healthcare coordinators across the state that can help support, and their job is care coordination. And they do manage all the complex case management, as Andrew has noted. So we do have that support as a way to help, because we do believe that the liaison shouldn't be the only person doing the care coordination. So right now, our plan is to rely on, or for Ola to be able to have them to sort of troubleshoot the issue and remove barriers and set up systems. And also then she can rely and is connected with the healthcare coordinators throughout the state. So right now, that's where we are. But I'll just stop there and acknowledge that, Valji, we understand it's a lot. So yes. Thank you.
I know we're at 11:30 and I'm coming under the wire here, but just, I don't know if this is a quick question about data sharing. If you have any agreements with any counties, and if not, or if like you see any benefits of data sharing with the counties here.
I understand. Sorry.
And I don't know, someone else maybe who knows more about this is going to talk to it. Who is talking?
This is Ola, but I see Emily's. I'm not sure if Emily can come off mute or not, but essentially, to my knowledge, we don't have any currently yet, but that we do have our contracts team and our MOU team that's really looking to see if we can start driving those, because I know that all of our MOUs have been stalled for additional edits that need to be made. So we hope to have something in place while we start executing those MOUs.
And Diana, I would just add that we learned yesterday, if the connection or the data sharing is related to care coordination, that we are allowed to share this information with the county, and they are allowed to then respond as well to us. So I think it's super important to think it's not stopping us from coordinating the care. Where we also may end up getting to is a place where we can share with the county, if they would agree and we can get through this, that we could share who we have enrolled at Kaiser, and then who is eligible. Of course, all of the foster youth would be eligible for ECM, so that if the social worker is reaching out, they can say, hey, and Kaiser's, they're working with X, Y, and Z, and they can help you enroll in ECM. So I think that's where we need to get, and we talked yesterday about how we can move that forward. And to our knowledge, it's not needed that we have an agreement for data sharing, but we want to take it on a county by county basis to figure out what each county needs and wants, and how we can provide and what is the purpose of the data sharing and what we can provide, and having those conversations county by county, I think will be super important moving forward. Thank you.
Susan, go for it.
Be really quick because I know we're at the top of the hour. I wanted to ask Ola, were your examples post removal or was it pre removal? And do you have any similar examples of how you intervened, maybe pre removal to prevent a removal from occurring?
Post removal, both of them. And I do not currently have any examples of pre-removal other than a case study, like a made-up story that could happen.
Okay, thank you.
All right. Yeah, we are past the 11:30, so I appreciate everyone that stayed on the call and the great questions and discussion that we've had after the presentation as we continue to learn how the counties and Kaiser are going to work together to meet the needs of this population. We are going to send out a survey again. Really appreciate you participating in the survey to help us at CWDA and CFPIC continue to support counties through this process. Again, thank you so much for being on the call, and I'm giving you back your time.
Thank you.
Thank you
Thanks.
all.
Thank you.
All right, bye-bye.
You, Ola, can you